Good afternoon, everyone. I'm Patty Brennan. I'm the director of the National Library of Medicine. It's my pleasure to welcome you to the 2018 Leiter Lecture, which is a collaboration between the National Library of Medicine and the Medical Library Association. I'd like to acknowledge that we have two members of the Medical Library Association board with us today, Keith Coggill and Sandra Martin. Could I ask you to stand for a minute and be acknowledged? Thank you very much. Keith is a colleague, directs the Library of the National Institutes of Health, so we have many collaborations. And Sandra, I'm going to have to ask you to stand up again because I'd like to now acknowledge the Board of Regents for the National Library of Medicine. If you would please stand to be acknowledged. My colleagues from the Board of Regents, thank you for being here, for your support, and for the opportunity to have the National Library of Medicine participate. I also need to ask Sharon Willis to stand. Sandra Willis is a senior cataloging specialist, and she is the organizer of this particular lecture. Thank you so much for all that you've done from the Technical Services Division. I'd also like to acknowledge my colleagues from the Friends of the National Library of Medicine, Glenn Campbell and Dr. Barbara Redmond. If you'd stand, please. The Friends of the National Library of Medicine is an important partner that brings forward and supports many of the initiatives of the National Library. It is a voluntary public organization. And now I have my very special opportunity to welcome home Betsy. Betsy Humphreys has joined us for the meeting. Now, today I'm going to be introducing Eric Dishman. And Eric has a public persona that many of you have already seen. But I've known Eric for 20 years. And I've known aspects of Eric, which I won't be completely sharing today. But I want to tell you that Eric once was a member of the Board of Regents of the National Library of Medicine. And as I was being recruited to take this position, I called Eric as a colleague and a friend and a wise friend. And I said, Eric, I'm thinking about this job. All the while, Eric's thinking, I'm thinking about a job there too. And so he was very helpful. His counsel was great, as it's been over the 20 years. And I come from my interview. I'm very excited. And I'm walking into an interview, and Eric is walking out of the same room. And I thought, are we interviewing for the same job? You know, he must have. But no, the best thing that happened the whole world, there was a confluence of two strong patient technology advocates, Eric Dishman and Patty Brennan, hitting the NIH at the same time, and they don't realize what it's coming to them. What it came from Eric's perspective, though, is bringing his 25 years of history in Silicon Valley as the Intel's manager of health strategy, the startup to figure out where technology was going to be in health, now comes in the service of our society. Through his work, Eric has been a passionate advocate, policy innovations, product innovation to make sure that we are able to find tools that help people live well at home. He was a member of the Precision Medicine Working Group here at NIH and then came to join what was originally referred to as the Precision Medicine Initiative, now known as the All of Us. And I model my All of Us, not federally paid for, necklace. Eric brings an energy to the conversation that no one in the world could possibly bring. And he brings this because of his long-standing skills as an anthropologist, as a scholar of how people live in the university, and as a patient himself. And because of his own passion and willingness to tirelessly search, he was able to reverse a 20-year process of kidney cancer to make sure that we had his talents to ensure health for all. Eric believes that he was alive to do this very product, this very process, this very approach to ensuring that the health of the public will be driven by knowledge of the public. I think you'll enjoy his comments. I have never, ever heard Eric speak that I haven't come away transformed, and frankly, with a little more work to do. So get your work ready. We're going to be going on. Eric, welcome, and thank you so much for being here.
Well, I just wanted her to keep going on and on and on. That was fantastic. Patty has been a great friend and scholar and teacher, I think we began our work together thinking almost 20 years ago that we could make personal health records widely available. And I have 3 failed startups on that topic. I can talk to you about why they failed, but it's like we are still on this journey to give people information that they choose to have about themselves and be able to sort of move forward with their health in proactive ways. So before I go any further, I just want to say thank you. You at the NLM and the NNLM have been wonderful at helping to get the word out on our launch, our national launch of the All of Us Research Program, which was less than 72 hours ago. Thank you. And we had members, we had NLM staff and NNLM folks and local librarians at almost all of the 7 sites, if not at all of them. I got to meet some of the ones in Detroit. They joined us for a little celebration on Sunday afterwards. I'm sort of lost in time and space. It's like it's like 22 months of holding your breath for this national launch, and I'm still not quite sure. But before we go any further, I just did want to do that. Thanks. And I'll talk more about the launch in a few minutes. I completely changed this around. I mean, Patty was asking, she's like, did you agree to do this knowing that was the launch date? And I said, yeah, I did. I'm not sure why I did, but I know why I did. It's because libraries and librarians have a special place in my heart, and quite frankly, they have been key to my survival from a very early age. And so I added some slides last night that just, I want to share some of those stories with you. People tend to think, I mean, they sort of fast forward to the end of my 23 cancer journey, and they tend to say, it was whole genome sequencing that saved your life. I'm like, well, technically, it was the Intel employee who donated the kidney to me that saved my life. But the whole genome sequencing, the electronic health record from all those years was key. But if I go back in time, well before I had cancer, in fact, when I was born, the role of libraries and librarians was a key part of even getting to the point in life where I got cancer. That's a picture of me with what I swear is the largest baby forehead in the world. You could rent rental signage space on my forehead. The rest of me, I was very premature. I was born without my hip sockets being completely formed, and the doctors initially told my parents he's never going to be able to walk. He'll be in a wheelchair his whole life. And they refused to take one doctor's view of it and started getting, and then this was unheard of in those days. You didn't just accept what the white coat person said to you. They started going to libraries, they started reaching out to other clinicians, and they, through a librarian and a clinician, found examples of a study that had just been done of a procedure that helps the hip sockets form the rest of the way. I was a cross-country runner in high school. I played all kinds of sports, and I meet other people who are my age who are wheelchair-bound because they did not have the information, and they did not have the people that were acting on their behalf to curate that information and get it to them in order to actually impact their lives. So, before I'm even sort of have language, the narrative in my household was, don't be a passive patient, right? Or don't be a passive parent. And it was the power of information that can really lead to ability or disability. And the notion of a second and third and fourth, I've used libraries from my second to my 152nd opinion, trying to sort of triangulate between lots of different sources. And it was both the space and the place, but the people who worked there that were absolutely key to that survival. Now, the other reason this is so dear to my heart is that's my mom. This was just taken a few weeks ago. She's playing Quiddler. If you play the game, do not play it with her. She'll kick your butt. And she was a school librarian in a very poor school in kindergarten through third grade in Charlotte, North Carolina. And I just remember when I would go with her, I didn't go to that school, but when I would go with her to work, and I would see, she always had the ability to find the right book for the right child at the right moment in time. It was uncanny. It was like, I've done a lot of field work studying home care nurses and home care doctors who, in the environment of the home, see the full complexity, the full picture of a patient's life, and can prescribe a set of actions with more context than what we're allowed to do in the kind of 15-minute sort of factory line frisking that so much of healthcare has been forced to become because of the way that we pay for it. And at that point, I was like, Mom, how can you know? And she's like, well, I know these kids' lives. I know what's going on in it. I can sort of read their moods. And she could just uncannily go, and I think of this as kind of precision communication, take all those variables and go find a book from her head, and she knew every book in that library, and hand it to that child, and it was exactly what they needed in that moment in time. And she did this for me as her son growing up in life. Now, if I fast forward a little bit, this picture here at the top, and I saved lawn mowing money and software programming money to buy that sofa because I thought it looked really attractive for my freshman year in college. I was diagnosed my sophomore year in college with a rare form of kidney cancer, told that I would have 9 months to live if I was lucky, went into a deep depression. And, if it weren't for another patient at the Duke Library, that's not the medical library, but we went to the Duke Medical Library, This patient who I met in a waiting room when I was waiting to have endoscopy done, she was an actuary, and boy, I got through my statistics classes in graduate school, but I'm a qualitative researcher because I was struggling with those. But she knew statistics really well, and she took me to the Leduc Library, and there we are with all these journals and things that the librarian had to help us find. And she's looking through them, and she's like, after a couple of hours, she's like, Eric, they don't know anything about you. And I was like, why do you say that? And she's like, there's been 2.5 studies about the rare cancer that you supposedly have, and both of them were with people over 65 or 75. They've never seen a 19-year-old, and they're trying to extrapolate from the average of the few studies they had to you and giving you this death sentence, and you're living out that death sentence. And I can tell you in the now more than 2,000 cancer patients I have personally advocated for, and I keep all their stories in my journal, it's like in general, the ones who accept and believe the numbers die on time, and those who get out of that mode and start looking for solutions and don't just accept that psychologically tend to live longer. And the problem is, this is when I really understood, none of us are average patients, and there can be huge evidence gaps, but no one tells you that when they're handing you this death sentence or this proclamation at that moment in time. So this Verna was her name. She was helping me sort of get out of that death sentence, and she also taught me to be a proactive patient, right? I mean, even though it had been in my narrative of my family, when I got the C-word diagnosis, I just shut down, and my faculties, and I have helped do cancer advocacy for some very famous Silicon Valley executives that you would know. These are powerful people who have just incredible drive and strength and knowledge and are data-driven, but the moment they got the C-word, it just shut down all of those faculties. And the first thing I have to do is teach them many of the same things that my mom, my dad, and Verna taught me. Now, I wasn't done here. I mean, libraries ended up being a whole part of my 23-year cancer journey. This is a picture of the University of Utah Library. So I would have my treatment up there, but also before I would do the treatment, I was in there looking at different journals, getting the librarians to help me find out information. And I discovered over time that I have superpowers in snow. It's not that I like snow. It's like I have a deep spiritual connection and need for snow. And if I don't get some of it each year, I think I would have been dead a long time ago. And so as I was progressing in the illness and the risk of death was becoming greater, I kept saying, I want you to optimize the side effects from the drugs you're going to give me for my ability to continue to hike in snow. I don't care about longevity. That's not what I'm optimizing for. This was a huge fight. And I actually had to go into the early days of electronic health records and show them. This is an animation because I can't find the images from back then. And I would say, in the nickname field, first of all, I go by Eric, my middle name. Call me my damn name when I walk into this environment. And the second thing is, all the choices that you present to me need to be optimized for my patient goal that says, I want snow time, not longevity. And it was a fight that took years and years to do. And honestly, we didn't then, and I would argue now, we probably don't have the search algorithms and the informatics in place to really optimize around goals. And in most electronic health records, there is still not a place for the existence of patient goals. You got to cram it in the nickname field or some other less used field in that environment. So this is what taught me that most of the system I was in, including all the side effects databases that were useless, were driven by liability more than livability. Because really trying to get in there and figure out which drug should I take based on snow time was an incredibly difficult search opportunity as we went through that. And then more recently, libraries are the places where I often meet the cancer patients that I advocate for. It's not necessarily that we couldn't get the same information home, but there's something about the physical safety of those places. There are people in there curating and helping us find and make sense of this overwhelming data. I mean, through the years, initially the internet was great for me, but it became overwhelming for me, and I was a technology executive in Silicon Valley, well versed in the tools and speak English and have money and means. And I would have to, the Stanford Medical or Health Library that was in the mall right next to where I would get my chemo was key, and in particular two different librarians in there to help me curate the overwhelm of all the stuff that was on the internet, and now just the frequency with which journals came. In the early days, I paid for and bought my own nephrology journals, but at great expense when I was a very broke graduate student. But I needed that help, and to this day need that help to search through the overwhelm of too much information. And it has always been, through all of these places, the compassionate curators surrounded by rich resources that made the difference between choices and life and death for me all along the way. So it's true that eventually whole genome sequencing and having my EHR together helped my doctors look at me and say, everything that we've done for you with 23 years was destined never to have worked, but we think we now understand the mechanism of your kidney cancer. We want to put you on a pancreatic cancer drug, and suddenly I was cancer-free after 2 months of chemotherapy at the very last hour before we walked in here. And I'm healthier now at 50 than I was at 19 when this whole adventure began. But the role of libraries, the role of information, the role of empowerment, and the role of curators was absolutely key. So I'm kind of left with some questions, right? In this era of hyper-information and connectivity, I wonder a lot about the future. What will a library become in order to continue to be responsive and life-saving for people in a world of patient-driven, personalized care, but flooded with information that's almost too much to handle? What's going to be the informatics that will allow us to not only listen to, have a space for in the record, heed and meet the unique needs and goals of an individual? How are we going to curate this increasingly complex information into precise N=1 action plans, right? We would come up with an action plan for me based on what we believe was the right thing to do. What's it going to take now to step back and say, with all this information and these new data types, how are we going to customize care to the unique needs of an individual within very complex changing worlds of behavior and emotion and biology and socioeconomics? And then how are we going to change our research assumptions and practices in order to deliver medical breakthroughs that can be individualized? The All of Us research program is not like a panacea that's going to answer all these, but I think we're going to discover things because we have the need and the opportunity and a platform to help us learn some of these answers as we sort of move towards this journey. So what is it? I'll give you an overview of the program, but then I want to share with you a little bit of our challenges and struggles for doing what I call precision communications, which is, I think, exactly what Jenny Dishman, my mother, was doing when she chose the right book with a bunch of contextual factors, which is exactly what was doing with most of those librarians who were coming in and trying to customize information and to me and communications to me that were going to empower me. If you step back, and this was true in my Intel career and coming here, like right when I left Intel, our ethnographers had gone out and studied researchers and practitioners, providers who were on the front edge of doing precision medicine care. Not just cancer, but certainly cancer was one of the pioneering areas. And out of that, it became really clear on a number of fronts. The first, from the perspective of patients and people, the vast majority of even cancer patients, let alone people with other conditions, are not getting precision-based care. We simply don't have the science and the evidence behind so many of those places to do that yet. And even in the places that were cutting edge in 20 countries that we looked at around the world, you would see an oncologist or a physician who was knowledgeable of this and had tackled the difficult learnings from it in an office right next to one in the same department, and one of them was offering you life-saving treatments and the others didn't even know they existed, and we're sort of poo-pooing the whole idea that genetics and behavior and lifestyle and all of those data would make any difference in what they were doing. So the simple reason why we need this is, from a patient perspective, we are still in a primarily average of who happen to be studied, trial and error kind of paradigm, especially if your illness is very, very complex at all. But from the perspective of the providers, right, it's not because they're doing bad jobs. It's because they're not equipped with the science or the tools or the time and the environment in which they live to be able to do that kind of customization of care. I mean, I mentioned that I used to study home care doctors in great detail as an ethnographer, right? And they were better equipped to take together. They were able to, if you think about it, pull the camera back from the understanding of the patient through the lens of a chart and see that, oh my gosh, they're in an abusive situation, or see that they have no air conditioning and live in Atlanta, Georgia, right? And see these other contextual factors that were fundamental to health. But our system today does not want context. It wants fast processing and moving on to the next person. So I don't blame providers for the lack of precision care options. I think they do miraculous things with limited tools and data to do as much customized precision care to the individual as they possibly can. When we went and looked at biomedical researchers in all of these domains, they were never getting to the science, because to start to collect these new kinds of data types was really difficult. They'd get a 3 or 5 year award from us at Intel and also a university grant that they had won through NIH or somewhere else. And they'd spend years of that grant just trying to recruit their cohort of people that they were going to study. Almost never were those cohorts very diverse in terms of who they were trying to get. And then they would spend another year trying to get the IT systems in place to deal with big data. So we were watching them never get to the science, and they were eating up all of the parts of their awards that didn't have adequate funding to build all of that infrastructure, and they just weren't getting to the science. So a lot of our questions became, how can we provide a public resource to address these kinds of user needs? And this is very much what I think about the All of Us research program being. I mean, I'll tell you, we get some critiques from other private cohorts that are out there, and I'm like, look, I will be the first taxpayer that says we should stop this study if someone else is going to recruit 1 million people with the diversity of data types and the diversity of people that we're going for, clean and curate that data and make it available for free to all researchers at the same time. If they're going to do that, I'll be the first one to say, let's stop spending the money on this. But they're not doing that, and that's why we are building the public resource that we are. So our mission here is it's really acceleration. How do we accelerate health research and medical breakthroughs that are going to really enable individualized prevention, treatment, and care for all of us, not just the people who happen to have been studied in our medical past? And I see this as 3 strategic objectives that we try to align our organization around. First, we have to nurture relationships with 1 million or more people from all walks of life for decades, and these are participant partners. If it is not a two-way street, we're not going to recreate the sort of look and feel of a local town like Framingham, Massachusetts across the entire country, right? And we've got to create ways that we're building those trusted relationships and providing values to individuals, or the rest of the program is dead. If we do that well, then we believe we will deliver one of the largest, if not the largest, biomedical data sets ever. And we're trying to make that easy and as safe and as free as we possibly can for people to access. They'll certainly be able to access it at some point, depending on how large the compute loads are and storage they need for their additional data. They're going to have to help pay for some of the infrastructure cost. But we are working hard to make this as easy, safe, and free for researchers of all stripes, citizen scientists to the top corporate and university labs that you would know about to use it. But even if we build that, will they come? And our 3rd strategic objective is, how do we catalyze a robust ecosystem of researchers and funders to use this public resource? We do not have the funding to fund the science. It is going to be the other 27 institutes and centers and outside funders that need to leverage this free resource to get the science done. But if we partner with them to help invent what goes into it, which we are, then there's a better chance that they're going to use it, and we'll be able to get to outcomes faster. Because think about it as a researcher. Holy cow, you have a larger cohort than I could ever create myself. It's more diverse. I can pop into a free browser to characterize it, and now I've got funding from this place to come do an ancillary study with a group of people I could never bring together myself, and you've already done 90% of the work of building the data environment and brought in a bunch of the tools to use. That's the paradigm. This should generate thousands and thousands of studies if and when we make this successful. Somebody needs to yell at me 5 minutes before you want me to stop, and wherever I am, I'll do it. So, the version 1 protocol, I'm trying to get everybody into the mindset of like, this is any other product like Silicon Valley or pharma or anybody else would create. User-centered design processes, you're going to start with a minimum viable product, and you're going to make changes over time based on what your users, the participants, and the researchers tell us. The version 1 protocol that we launched nationally on Sunday, and we had done a year beta phase with about 47,000 people signing up, and they're somewhere in the process of this, and about 27,000 of them before we had launched on Sunday had finished this entire first protocol. So it's basically you enroll and consent and authorize to share your electronic health record data. Right now we're recruiting 18 and above. We're working on a plan for children, and that'll launch in summer of 2019. A little bit more logistically difficult and ethically difficult to make sure that we're doing that. The only folks we can't include right now are those who are incarcerated and those who cannot cognitively consent for themselves, and we're working on plans to deal with that. You can imagine in the incarcerated situation, it's a nightmare with 50 states with almost very different rules about the laws and rules for people to participate in research. And then the second piece of this is there's 3 initial surveys, kind of the basics, overall health, and personal habits. There's a 4th survey that if people have been in for 90 days, they'll get on healthcare access and utilization. And then we'll do additional surveys over time, and there's a bunch of them in work. Those surveys typically are taken from NHANES and other places. We're not inventing instruments ourselves. But in almost every case, we've had to work to take those instruments and work to get the language down to 5th grade reading level, which has been our current goal. So we got to do rewrite them, test them, make sure they're still efficacious, translate to Spanish, get the IRB to approve them, and put them in. So it's quite a process to actually get those through. Some people will be invited based on our scientific goals, and that is demographic, medical, and geographic diversity. If 10 million people sign up and want to do all of those parts I've just described, that would be fantastic, but we'll sample from those for sampling targets to achieve especially those who have been underrepresented in biomedical research. You'll see a white paper on this coming soon. There's 9 categories. We had to do a ton of research with partners across NIH to actually come up with a definition of truly who has been underrepresented in biomedical research. Certainly race and ethnicity is a big category of that, and that will be one of the primary focus for us, as well as socioeconomic status and age, and the intersectionalities of a lot of those things. But if you're invited to then come in and give simple physical measurements, that's the list. It's not a physical exam. You leave your clothes on. There were some folks who were still amazed, like, I don't know if I want to take my clothes off in front of your administrators. Like, you're not taking your clothes off unless you just need that to actually have your height and weight done. And then a biosample of blood and urine stored in the biobank at the Mayo Clinic. And coming very soon, in a matter of weeks, we'll start around, probably that will last a couple of years, for what we call BYOD, bring your own device. If you already have a wearable device or phone app, we're starting with Fitbit, and you want to share that data with researchers, making it very easy to do that. My guess is, and this is an area of research that I funded a lot of out of Intel and did a lot myself, is that at some point we might have to create a consistent device for all million people or have the market do that for us. We don't have the money to do it right now as we get going with whole genome sequencing. You know, everything we do is times a million. So everybody comes to me with like, hey, just add this and just add this. And it's like times a million. And then people step back and go, oh, well, that's pretty hard to scale up. So this is where we are, but we've got pilots looking to get richer electronic health record data, pilots with the health apps, fitness wearables, and then starting late this year, we will start doing both genotyping and whole genome sequencing on those who provided samples. And we're going to do a return of results, a responsible return of information pilot with 20,000 of our participants chosen for those diverse parameters from those who have joined already to really understand how do we properly do this. People keep asking me, why haven't you started sequencing? It's a genetic study. I'm like, it's not a genetic study. It is a complexity of life study over a long span, and we're collecting multiple data types. Genetics is one of many. It just happens to be the one that everybody thinks is sexy and very expensive right now. We will start that process. There's not enough sequencing capacity. We will make one of the largest orders in history, if not the largest order in history for whole genome sequencing, right? And it's not the same thing as 23andMe. I mean, even the sort of biotech press is getting this wrong. They're like, well, just go to 23andMe. I'm like, that's not a whole genome sequence. We might partner with them because they've got some great visualization tools or any of the other commercial places, but there's a big difference. But the other gap is, back to curation and context, there's not enough genetic counseling capacity for what we actually need to do. Even our top-tier health provider organizations who are recruiting from their patients are like, we don't have the capacity to add now doing our patients who need it for clinical reasons as well as for research reasons. So we're trying to figure out how do we scale up this counseling capacity because we have to do this in a responsible way. I mean, you could fill out this chart a million times over, but I mean, if you think about the kinds of questions that this resource could answer, it's like, let's think about the epidemic of chronic pain with 100 million people, or just take lower back pain. We have some understanding of it, but we do not have a longitudinal study with rich data sets looking at the intersectionalities of these data to perhaps segment chronic pain into much more effective categories that we can then do prevention and targeted strategies for. I did a ton of work for years with the Alzheimer's Association, right? And we're coming to understand that all these things that we lumped under the category of Alzheimer's as many different kinds of dementia. Can we start to look at the intersection of behavioral and other data to help that further segmentation and targeting? Or can we help develop better pain meds that aren't addictive? Think about diabetes, same kind of problem, right? You think about, you can see it in the phenotypic data that comes in through electronic health records. The variability of symptomatic responses for about 10% of the population that has diabetes is huge. And we don't really have great ways of sort of saying, maybe I'm making this up, right? But the diabetes researchers tell me maybe we'll discover that there's 25 different paths to this, and we're going to treat and deal with those in very different ways. Or more cancers, and particularly a big focus on disparities interventions that can work. We know about disparities. There's great research that show them, but we do not know very well how to actually go deal with them, and we don't have an environment where we can test them in comparative ways. You could leverage this platform and this group of people to really make some progress there. These are just a few examples. The basic building blocks of the program on the bottom here are what we call our 3 networks. So we have a participant center network, a health provider organization network, HPOs, and then a communications and community network partners. Between these three networks, so the direct volunteer are folks like Walgreens, are folks like, you go there, I get lab work there all the time, one of the most common labs in the country. Quest, yes, thank you. Chemo brain's a real thing. And I'll talk more about them in a minute, but they have the ability to do pop-up capacity in places where just we don't normally reach people. The health provider organizations range in size from federally qualified health centers, who are really key to our diversity strategy, to large players like the VA and all points in between. There's 125 of those locations currently open, recruiting from their own patient pools. Soon, we'll get the IRB protocol updated that they can recruit family members and others who may not be part of their health plan or associated with their particular clinic. And then a network of community partners who, at the end of the day, are often the face of the program locally. These are national partners who have a local presence. In addition to these 34, in fact, I'll show it to you in a minute. In addition to these 34, every partner has to have a community or a participant advisory board, and every one of those HPO partners also has local community partners. So if you add it all up, it's probably about 250 or 300 organizations that are just helping us to localize our messages to folks who are in these different communities, which is the topic that I'll end with. So these are pictures from the launch. You can go to you just go to joinallofus.org, or you can go to launch.joinallofus.org. We chose 7 sites around the country. I was in Detroit, there on the football field. This is Abyssinian Baptist Church in Harlem. We've got folks in Kansas City, folks in Pasco, Washington. So a real mix of communities, grassroots events, health fairs, and those kinds of things to really both be and be perceived that we are focusing on diverse communities around the country, and chose diverse sites to actually do these launches to get that off. And it was very successful in that regard. Our goal, by the way, for underrepresented biomedical research is that 70 to 75% of the million people will be underrepresented in biomedical research by those 9 categories. And I will go into more detail on this. That's a 2-hour talk just to explain the hell that we went through to try to figure out what are the categories underrepresented in biomedical research. So the launch and design approach to the event is sort of exactly kind of the design principles that we have as a whole organization. So there's 3 design principles I want to talk about here because they show the challenge of how are you going to do research differently. And the first is that all healthcare is local, so maybe all health research should be local as well, right? So we're trying to figure out how do we build local capacity convenient to where people live, work, and play so they don't have to be near or associated with a large academic medical center to participate in research. Now, many of our partners are large academic medical centers, but their health plans have a reach in much greater rural and other kinds of communities than just the main urban center hospital does. The second is meet people where they are. So how do we orient to their cultural, social, literacy differences that make a difference? And the third is one that from long ago at my Intel days, I've always called double value. If we're going to do research, then we want to collect data that's going to be valuable to researchers, but we want to search as much as possible in ways to give value back to the participants who are providing that research. So we're trying to choose science and data and assays, and we have participants involved in our governance and our science committees. They were involved in our requirements gathering workshops for what science and what measures should we try to capture to really try to figure out, whenever possible, how do we deliver double value for what we're going to take the time to collect. Now, I've given this talk at AMIA a number of times, not this talk, but I've used this framework called Shift Left for now probably 24 years of my 27-year Silicon Valley career anyway. And I focused on independent living for seniors in my own research in geriatric care and was desperate. Like if my tombstone says one thing, I hope it says, here lies Eric Dishman. He helped to end hospitals and nursing homes as we know it. And my goal was always to shift care to the home and the community as much as possible. It was the only way out of the economic paradigm or problem that we saw. And this was what guided a lot of the startups I did on telehealth and independent living technologies for seniors and the research that we did. So if you think about actual health care, cost of care per day, the amount of expertise needed, if you're in an ICU, there's a bunch of very highly trained, very expensive people and equipment around you in this kind of medical mainframe that's keeping you alive at the cost of an enormous amount per second or per dollar to actually do that. And it's not a pleasant place to be, right? It's not a pleasant place to pee either, given how many times I've been in an ICU. And nobody wants to be there, right? I mean, you would, for quality of care and quality of life, you want to be at your home or in your community or at your workplace. And you've seen over the last decades the shift of healthcare finally starting to put minute clinics in, so it's the convenience of the grocery store. And we've been on this trend with technology. It was 9 years ago now when an AED, a defibrillator, was the top consumer electronics device requested for Christmas from men, right? I mean, and that's a total shift left. This was a big piece of big equipment that was expensive, that you had to be an expert operator to use, and suddenly it's a piece of consumer electronics. And those trends are continuing. Well, and if you think about it, it's not that hospitals need to go away. You reduce their footprint, and you take some of that capacity where we're doing primarily chronic care management or chronic care exacerbations management, and you're distributing that capability in that capacity into other parts of the community. Well, I would argue the same thing that I've been preaching for 20 years about this is how we save healthcare is true for research. We've got to shift left towards a more personal, distributed model of health research. So there's going to be certain pieces of equipment and things that, yeah, you need to go to a mainframe academic center to be able to capture that kind of imaging data. But we need to move up from, what can we do in a primary walk-in clinic? What can we do in a pop-up clinic that's near somebody in their workplace? Or how can we, so that they could do it at home but with some professional help, or even with a family and friend help, or do it yourself, right? And as you do that, you're going to be able to collect data more in the wild, in the everyday life. The quality of the experience will be good, and you're going to be able to capture new data types that are going to get you insights that you couldn't get in all of those other locations. So this is part of the experiment of what all of us is trying to do. So we're trying to build local capacity to meet people where they are, well, in part by having that network of health provider organizations and familiar doctors and familiar settings to them, but also making sure that we're not just reaching to the urban center, but out to the extensions that most of those players actually have through their health plans. This direct volunteer network that we put together is very magical. Through the partners that we have today, we have the ability to reach where 95% of the people in the country live in the United States within 20 to 35 minutes. Now, we can't turn that capacity all at the same time. We don't have the funding to say, yes, every Walgreens is ready to do this for an all of us research participant. But we have the ability, we're building additional locations and sites as we see where people in communities that we need to reach are doing, and we can either put a permanent site there, or we can do pop-up capacity and say, hey, we're coming to town for 6 to 12 months. They might have done the rest of their surveys at an event. If there's events that are happening if you're not computer literate where people can help you through that process, or you may have just done it all online, but at the point when it comes to do the physical measurements in the biospecimen, we've got to put that trained capacity there so that we're getting quality data samples across the country. The other thing that we're doing is taking a sort of journey exhibit, right? So this is it right now, and it's primarily in education mode, and sending these mobile exhibits into parts of the country right now, just trying to teach people what is precision medicine, what is the All of Us research program, what is research. But we'll be converting those many to be able to do physical measurements and biospecimens. Or that comes to town, sitting to with a local library through our partnership with the National Library of Medicine, and through our partners can bring tents with clinical capacity in or a building nearby to go be there for weeks and weeks and weeks at a time. So that's the kind of examples of what we're trying to do to get to people where they live, work, and play. And these are some of those partners. So you can see the direct volunteer network partners at the top, and you'll recognize some of those. A lot of people don't know EMSI, but they can reach every zip code except for about 5% of them in the United States. Every insurance company uses them. They do in-home physicals and evaluations for life insurance, for employee testing, and other kinds of things. So having a partner like them, we even have the ability to go into people's homes for when it's too frail or too unsafe for them to be able to get to one of our local sites. Now, obviously, that's more expensive. We can't do it for all 1 million people, but this is the envelope that we're pushing for trying to be able to reach. In terms of meeting people where they are culturally and socially and literally and literacy-wise, I mentioned these community partners. Yes, there's going to be a lot of people who are not digitally savvy. These community partners are working to help create events and other mechanisms to help people on board. We're working on our protocol change with our IRB to help let neighbors and others help them through that process, but making sure that that person is still consenting as they go through that experience. The NLM partnership in terms of getting these public libraries. Ginny Dishman would have been doing this in a heartbeat if she was still a practicing librarian at Albemarle Road Elementary, doing these community fairs and health events with libraries, and also using libraries as a digital access point for those who know how to use it but don't have access to their own technologies is key. I mentioned for right now that we're pushing to the 5th grade reading level. The consent experience, like people who, I get some people complaining saying, why is it all videos? I just want to go through the videos really quickly. And it's like, well, it wasn't for you. But it's like I could read much faster than that. It's like, just understand that we're trying to create an experience that can include a lot more people than have traditionally been brought in. It's like, go through the videos, read the transcripts, and get through that. Right now, we're in Spanish and English, and then trying to figure out what we're going to do next in terms of the program in that regard. And the last piece of this is we are going out and meeting with, a week after, or within a week after the first protest nationwide in terms of changes in immigration policy when everybody was at airports. Here we have San Ysidro Health Center on the border in Mexico, and it's like suddenly they can't get their patients to come in for their appointments, let alone come in for a research study. How do we have those explicit conversations with them about the political reality that they live in? How do we teach them what certificates of confidentiality are? I'm amazed that most federal researchers and even NIH researchers do not understand that the 21st Century Cures Bill for all federal research makes it mandatory to actually protect research data from anybody trying to come use it from another agency, whether that's at the federal, state, or local level. And if it was somehow leaked, you still have immunity from prosecution based on the data that would be used. If we didn't have that protection in place, can you imagine how quickly the scientific engine could shut down if we can't assure people that the data that they're donating for research purposes is not going to be used against them in a court of law? So trying to be transparent with people about what these are and what they cover and what their limits are, because there's always limits to every protection, is part of the approach that we're trying to take. And these are some of those national community partners, but again, there's many, many more. And most of these national community partners, some that are provider-focused to educate providers and nurses, and some that are patient-focused, there's many more behind this in terms of each local award having those as well. And many of those were key to doing our launch because they could reach in any state. Oh yeah, we can put capacity in place there with community partners there. The double value, is really about, again, trying to bring value to the researchers and the participants. So one of the things that we're doing is driving a participant-centered design process where they're, again, part of the development of, hey, this is an important health issue to our community, and working with others to figure out what data would need to be collected in that regard. There's other ways that we're trying to do it in terms of mHealth apps, right? This is fun to play. It's useful for the researchers, and people enjoy it. I started doing that kind of work when I first met Patty a couple decades ago with just seniors playing solitaire and looking at, number of games lost and how long it took them and the changes in those patterns over time. So we're doing all of these kinds of things to try to figure out with every point. And then, unlike most research programs, we are returning everything from raw data to results back to participants for those who want them. But I mentioned before, we're not just throwing the data out there and saying good luck. We're putting infrastructure in place to try to help contextualize, get that information to their doctor if they want, provide counseling. We're limited. We're not care for anybody. But it's our responsibility to do the best we can to actually get them to make sense of that data in a responsible way. I was going to give you an example there from some old work. So let me wrap up for these last few minutes with I'm going to share with you some of the challenges that we have. And I started with just thinking about some of the imprecise communications I have known as a patient, right? So there's the upper left-hand corner. It's like, well, we really don't know what to do with you. We're just going to do the cancer wheel one more time. And I swear, most of my life felt like that for those decades. Or, somebody looking at you and it's like, could be anything. That's way too general of a general practitioner, right? Or more often for me recently, the doctor will see you now. Here's your medical jargon dictionary. People think I have an MD because I go out and do patient advocacy. Now that I've joined NIH, they think I understand everything. All my doctors now are just like, blah, 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 blah. And I'm like, I heard the word Eric in there. That's the one that I understood, right? So we're trying to start doing precision communication as part of our recruitment and our messaging to participants that I think will teach us things about how we do this better for actual patients themselves. So our goal right now is right message for the right person at the right time. And right to us means it's authentic and truthful. It's also achievable, in other words, to get that message to them in that way, and it's effective at actually getting the message to them. We started out with these made-up fictional personas. I'm a very much persona-based design person, because when we first started talking about both what's a participant and what's researchers within our consortium, they narrowed to a very definition very quickly, and it was like, there's no such thing as a participant. So we came up with this 8-part segmentation with not everybody's happy to join research. There's those who are suspicious, they have no time, they're too much governance, just to start to force us to realize there's going to be very different audiences of people that we're trying to reach. And now, as we're starting to get analytics and data back, I suspect a qualitative, if not a quantitative segmentation will emerge based on the actual people that we have that will help us know how to do this. We're doing community-specific materials, so we talk about Tuskegee in very open ways with African American communities and take the most tragic things that we've done to people with Hispanic and Latin American backgrounds and talk about those studies in very specific ways. And here's the things that we're doing differently that would prevent that from happening again. We're doing a digital marketing strategy. And this is not rocket science from the standpoint of those who do digital marketing, but they don't do this very much in research. So we are applying target marketing databases and strategies to research. Now, don't walk away and think that we're selling our data back to Facebook or whatever, Cambridge Analytica, that's not the case. But we are trying to understand, with a wide range of literacy, a wide range of relationships of trust, a wide range of preferences, how to target those messages, and doing A/B testing of different messages, mediums, and modalities to do that. And I believe we have to do this. We are fighting for attention in a very media-saturated world, and we've got to get people's time and attention and engagement, so we have to use a wide range of things to do this. I think it's our responsibility to achieve the diversity goal. Now, when we did a Twitter chat yesterday, I saw lots of feedback. People do love to give me feedback. This anthem video that we have, that we played at the beginning of it, your anthem video is coercive. No IRB would ever approve this. Well, they actually did. You are trying to trick people into joining by doing emotional appeals. Your national launch was just marketing hype. Yet, many of our participants in engaging with us and our community partners are like, you have to give us this, or we will not be able to be successful to recruit diverse communities in any communities. And there's never been such a thing as an average or general audience, yet many research studies pretend that there are, and they appeal to one that's incredibly literate, incredibly tech savvy, and incredibly health literate, and thus we start to leave people out. And I don't believe just the use of the rational, omniscient, white male scientific voice. It has coercive powers of its own. I mean, look at the supplement infomercials any Sunday afternoon on the dead parts of television. Scientists, scientific-looking people, white coats. It's like, this confers the power of credibility. This must be a real thing. Go take it, right? So let's not pretend that all the messages that we do don't have the potential to be coercive. But there are very good points in some of these things that people make. I went through 2 decades of dashed hopes, extra expenses, paying out of pocket for new drugs that insurance wouldn't cover, and very painful side effects. Interferon was supposed to save my life, and it was one of my 3 near-death experiences. Interleukin-2 was supposed to do the same, right? I can't say the word right now. Yes, thank you. I called them shark shakes because the ones I had to do were from shark cartilage, and you had to drink them, and they were very nasty. I went through this. I mean, these are more recent examples. We can't pretend that our headlines don't continue to hype this. Right now, it's CRISPR, right? I mean, I saw the 60-minute special with the guy saying, within 2 years, we think every genetic disease will be cured, right? I hope so. Wow, that's a lot of expectations you're building out with a lot of us. So there's real ethical issues with this kind of precision targeting that we're trying to do. So in general, we're trying to get people excited, but don't overhype. Don't coerce, but do relevant, meaningful targeting. Don't undermine the faith in current medicine, but do critique it and show what some of its downsides are. Don't blame providers, but do show the system that they're in has great blame. Don't reify the stereotypes, but do cater messages to interests and concerns. And don't condescend, but do simplify the protocol, the surveys, the assets, so it includes more people. So we're getting data and feedback that are going to help us understand these boundaries and these gray areas in effectiveness. And I just end with this. If I really think about what we're doing, and it's really just started to percolate into me 36 hours ago when I started to prepare for this, but it's so profoundly true. We're building a library with the need for an army of librarians. For our participants, we're going to have a library of data and information for 1 million unique individuals. How do we make it findable? How do we make it usable and useful? How do we share raw data with people, and what are the standards? How are we going to help them with visualization and interpretation from lab tests to results and even their EHR data? And we're building a library for a wide range of researchers. We're going to have a library of data and information for citizen scientists all the way to corporate labs and Nobel-winning prize winners. How do we train them in ethics and policy? How do we clean and curate that data? How do we de-identify it effectively? How do we visualize this new complex data? You work on these kinds of issues all the time. So what I would say is we appreciated your help in the national launch and getting the word out this week. And I hope, like you are at the beginning of a long, multi-decade journey that we can start to figure some of these things out together. And I can't wait for it. It's going to be a blast. Thanks so much. Yeah, as much time as you like.
Amazingly, Eric has left time for questions. Now, I must say to our MLA colleagues who are online and the MLA board, we can't take questions directly from you. But if you'd like to email Eric questions in the future, his email address is eric.dishman, not James, eric.dishman@nih.gov. But for those of you who are here in the room, let me ask you, please, Eric, we'll take questions. Just make sure you turn on your microphone so we can broadcast your question.
I'll make you choose.
All right. Okay. Questions or comments? Gentleman here.
Not sure if it's working. It is. I saw that you were partnering up with the VA. Just curious, is that going to be the MVP partnership? I know they've got several 100,000 volunteers already, so that's going to go into your network?
Yeah, it is a partnership with the Million Veterans Program. They have about, I think, 650,000 people with mix of data sets. I mean, you're getting more and more data from folks all the time. So they are one of our health provider organizations. They'll recruit from there. They are working to make MVP broader than just to the veterans, but to the veterans' families, as well as talking to DOD and TRICARE to try to expand it to sort of active military families. So as they expand, they'll be able to expand for us as well as we go forward.
So with that then, and knowing the clinical systems that they use and that the purpose of AOU, or all of us, is to aggregate clinical as well as genomic data, what are you doing on the normalization side of the house? Has that been discovered or talked to?
Yeah, I mean, to a certain degree. Right now, every one of our health provider organizations, including the VA, when they applied, had to go through a process that we called a data sprint that showed that they could send in an OMOP standard the particular data that we were getting in the Rev 1 push of EHR data, that then once you authorize it, it just continues to do that in batches. Now, for our direct volunteer partners who may or may not have a doctor, let alone be associated with one of our health provider organizations, there's 3 strategies that we're taking. One is a program called Sync for Science with 4 of the top EHR vendors in the country, including Epic. And those pilots have just started in 13 sites around the country. But it's basically leveraging the participant portals that are built into the software and an API that we built to be able to try to pull that data in. I think it's working pretty well because I know Apple's built to the same standard and they're out talking about all the work that they're doing. So it's like, okay, if they're going for it, it seems like. But we're going to do our pilot, make sure it's all there and useful. We're going to do a pilot with, I might get the numbers wrong, somewhere between 15,000 to 25,000 of our participants, some of whom already have EHR data coming in from an HPO and some who don't, with aggregators. So the folks who are, and it's very expensive, you could not scale this to 1 million people. But we want to look at that data and compare it in terms of its usefulness and utility and the challenge of cleaning and curating that with regards to others. And then there's a third piece where some of our partners like EMSI have built direct relationships with some of the HIEs and sort of the back-end systems of a lot of these providers. And they have a surprising amount of wealth of data that they can actually pull in. And then there's some others that are coming. So part of the challenge, and I've been trying to get Congress to understand this, it's like it's great that we've increased EHR usage by clinicians to the amazing numbers that we have, but the ability to still get that from people and make a holistic, rich record and make it useful for researchers is a long, expensive process. I actually think, even though whole genome sequencing cost is not coming down nearly as fast as I need it to, I think our total cost to get a rich longitudinal health record for our participants and for the researchers will be our second most expensive item, the first being the recruitment network to not only recruit, but retain and build these trusted relationships with people longitudinally.
Another question. Jerry.
So first, let me just say it's incredibly impressive what you've accomplished in the 20 or so months that you've been working
Yeah, we're not quite 2 years old yet. We feel like toddlers, but we're running fast around the hallway, though.
And I'm really pleased that we at NLM have already found ways to interact with you through the national network. You're also, though, so my question, though, is as you are also trying to work with the research community, and you have to some extent, ask to be all things to all people because
Yep.
of all the different kinds of questions that researchers could ask. How do you think about that, and how do you sort of accommodate all those competing demands and figuring out what's going to be in the research protocol? What data are we
Yep.
going to collect? And how do we make sense of it? I guess my question is, when I have something I want you to collect, how do I make sure it gets on your list?
Yeah, yeah. Well, I mean,
Let me repeat for just a moment
Okay.
for those in line to hear. So
good. I
first
need
of
more
all,
time to think about my
great
answer.
praise for what's been accomplished in 23 months, and I would echo that also. It's an astounding, almost a land speed record for a government initiative. I also, though, heard Jerry's question saying, now, if you're going to attend to the research first of all, how did you figure out what they might need? Secondly, how did you determine which data sets would work for the largest number of groups? And third, how might we get a new data element in if suddenly it becomes important to know whether or not you have spaghetti for dinner or your hair is blue?
So requirements, requirements, requirements. So one of the things I'm trying to bring is a requirements-driven design and development process that's very common in almost every industry in part of the world, in every part of the world. We just finished was in April. That's like dog years to me. That was like 68 years ago. But in April, we finished the first what we call Research Priorities Workshop. We asked all 27 institutes and centers to invite other funders in their areas, intramural and extramural experts on their particular topics. And then we also brought patients and patient advocates into this environment in a multi-day workshop, and I put them through a classic requirements-driven process that basically goes like this. Pretend the entire 1 million person cohort program is designed to just advance the scientific and medical breakthroughs in your narrow area or large area. What are the most important research questions you would ask of it that something this size is the right tool and something this diverse is the right tool to answer? All right, what kind of research questions, what kinds of studies would you do? Well, for those studies, what kind of data would you need to capture? All right, what are the methods to capture that data? And if you have a very specific spec, then tell us that. The public before and then during the workshop generated 1,300 use cases, very specific. I was like, don't stop at the level of, we want you to cure diabetes, that's useless. Like, go down very specifically into the study that you would have, your dream study. We're then just looking for common ingredients across there that are scalable to 1 million people at a reasonable cost and would have multi-field impact. So what we'll pay for out of our program are those ingredients where we can show this is going to have multi-scientific field impact, and other things that can't scale to 1 million people. That's a great candidate for them to apply and use the resource as an ancillary study. So that requirements-driven process will just go on and on into the future. And what I tried to get people to do is to say, this is low-hanging fruit that you could do almost immediately. This is medium-term stuff that we probably know how to capture the data for, but we need to have some ideological battles on which data capture methodology we're going to do. And there's some things that we wish we could capture, but we have no idea how you could capture that data. Those are great opportunities for partnerships with the National Science Foundation and others with engineering organizations to go say, hey, there's some long lead work. And I'll give you a simple example. If you look right now, there are 2 companies who have non-invasive blood pressure cuffs that are approved by it's not a cuff, it's non-invasive, it's doing time of flight measurements with sensors on the body. They were in intensive care units only, initially. There's no doubt that that technology can be shrunk in cost and so forth and moved to where we could probably, within 5 to 7 years, get to the point where it's affordable for all million people to get blood pressure monitoring, like without having to think about it, without having to do it, and not the lab effect and not the once a year or once a month monitors that you get now that we all know are just sort of really useless given the variability of blood pressure. So that's an example of one of those things where we can say, here's a need by lots of people with research, here's an ecosystem that's working on it, and then we'll work on a collaboration with them to get that and make that scalable to 1 million people and arguably to all people at that point.
One quick question, Clem.
Actually, 2 teeny ones. One of them is, are you using fire with that thing with Epic, and the other? Okay, and the second
Yes.
one is...
I know you would kill me if we weren't, so
Yeah.
you know.
I know it's a hard one, but is there an opportunity to get some sort of comparable small random sample just to compare what you're not getting or how it's different if you're getting the non-random sample?
Yeah, I mean, our science committee has been talking about that and doing that. I mean, When we did I didn't understand these issues because I was the tech guy on the original committee, right? We had to make some strategic decisions, and with the preponderance of people that were involved in that, one of those big ones was, are we going to be a cohort of cohorts, or are we going to start afresh? So even in the case of the VA, we're starting afresh. They're going through our whole protocol, and that's the only cohort partnership that we have. And then the other was, what are the strategies to deal with self-selection bias and random comparison and all of that? And we haven't decided exactly how we're going to do it. Some of the institutes have talked about, well, maybe actually we'll do a small one in our area for comparable to our issues, but we haven't sort of sorted that out. I mean, there's a bunch of those thorny issues that are coming, and we were like, look, we're not going to have anything if we don't start building the relationships and start collecting some basic data, and we've got some time to figure some of these out. We anticipate the researcher portal with the first batch of curated data will come out in the first half of 2019, but we'll start doing some alpha and beta tests of that in late 2018. I should just mention for this audience, it's all in Google Commercial Cloud, FSMA 2 moderate security process, and we're making people come to the data. You can't copy it out of the system. When people say, oh, well, you won't have enough compute power for us, it's like, yes, we will. There'll be enough compute power for what you want to do. You can bring your data into it. But to really try to protect the identity of the participants, we felt like this was the way. It's not that we don't believe in distributed analytics, we do, and I think it'll be a multi-model, but all of this data is going to be housed and protected within that environment that we're building, and I can't wait to start showing you some of the working prototypes of the containerized environments that we're building for researchers. I think people are going to like it once they actually understand what's really in there.
Please join me in thanking Eric for his presentation.
Thank you.
And on behalf of Barbara Epstein, who's the president of the Medical Library Association, and myself, Eric, you have to come back.
Oh.
On behalf of Barbara Epstein, MLA president, myself, we want to present Eric with a small certificate of his acknowledgement of his being named the Joseph Leiter Lecturer. Congratulations, Eric.
Thank you so much.